Welcome back to Modern Medics, your trusted roadmap through the complex world of clinical medicine and board exam prep.
Today, we're diving into one of the most high-stakes, high-yield topics in internal medicine, hyperkalemia. Yeah, that deceptively simple lab value that can spiral into life-threatening arrhythmias.
We're here to help you, the listener, cut through all the clutter and really nail down the must-know information about hyperkalemia, how to diagnose it, how to manage it, the whole shebang. And we're going to do it with a focus on advanced reasoning and how to ace those exams. Think of this as your high-yield guide to feeling like you've got hyperkalemia totally under control.
We're going to break down diagnosis into a clear step-by-step process. It's almost like a choose-your-own-adventure game, but with lab values and clinical findings.
Oh, I like that.
And then we'll really get into the nitty-gritty of managing hyperkalemia, going over the doses, how long each treatment works, and those critical little things you absolutely have to remember, both for your exams and when you're actually taking care of patients.
So important. The sources we're using today are all about hyperkalemia from an expert's point of view. They get right into the details of what's relevant for board exams, whether you're studying for the USMLE, ABIM, or MRCP. We're talking detailed explanations, step-by-step algorithms, real-world scenarios, and those golden nuggets of information that the boards love to test. By the end of this deep dive, you should feel way more prepared to tackle those hyperkalemia questions that always seem to pop up on the exams. So, all right, let's break it down. First things first, when you see a potassium level that's high, what's the starting point?
Well, the very first thing, and it's super important, is to make sure that what you're looking at is actually true hyperkalemia.
Oh, okay.
It might seem kind of obvious, but it's a really common trap, and examiners love to throw these curveballs.
Wait, so you're saying it might not actually be high potassium? Can you expand on that a bit?
Exactly. What we're talking about is pseudo-hyperkalemia. It's a falsely elevated potassium result that happens because of something that went wrong before the blood even got to the lab.
Nice.
The usual cutoff for hyperkalemia is a potassium level above 5.0 to 5.5 milliequivalents per liter. But if something happens to the blood sample, you might get a number that's higher than it should be.
Okay.
So the takeaway here is that the number on the lab report isn't always the whole story. You always have to think about whether something could have messed with the sample, especially if the patient isn't showing any symptoms you'd expect.
Got it. So what are some of the sneaky things that can go wrong with the blood sample, those pre-analytical errors you mentioned?
Well, one of the biggest culprits is hemolysis. If red blood cells get damaged during the blood draw or afterwards, they spill their potassium into the serum, and that bumps up the potassium level. Sometimes you can even see that the serum has a pinkish tint if there's a lot of hemolysis. And then there are other things that can happen too, like leaving the tourniquet on for too long, the patient clenching their fist too hard, using a needle that's too small, not storing the sample correctly, or waiting too long to separate the serum from the cells. All these things can affect the potassium level you get.
Wow, so there's a whole list of things that could go wrong just in handling the blood sample.
Absolutely.
So, if you suspect that one of these things might have happened, what should you do?
If things just don't add up, like if the patient isn't showing any symptoms of hyperkalemia or their kidneys seem to be working fine, but the potassium level is sky high, that's when you really need to think about pseudo-hyperkalemia.
Makes sense.
Look carefully at the lab report, see if there are any comments about hemolysis.
Right.
And if you're still not sure, the best thing to do is just repeat the test. But this time, be super careful to do everything by the book when you're drawing the blood.
Okay, that makes sense.
Yeah.
So the first big decision point is it actually hyperkalemia?
Yeah.
If it is, we move on. If it's not, if it's pseudo-hyperkalemia, then we don't need to worry about the potassium itself.
Right.
I've heard this is a pretty common trick question on the USMLE.
You bet. Examiners love to see if you're paying attention to these little details about how the blood sample is handled, because if you miss pseudo-hyperkalemia, you might end up doing things that aren't necessary and could even be harmful.
Okay, very important to keep in mind. So let's say we've confirmed that it's real hyperkalemia. What's the next step in figuring out what's causing it?
All right, so the next thing we got to do is check the patient's acid-base balance.
Okay.
The best way to do that is with a blood gas analysis. You can do it with either arterial or venous blood.
Okay.
What we're looking for is the pH and the bicarbonate level.
All right, and how does the acid-base balance connect to hyperkalemia?
Well, if you see metabolic acidosis, meaning the pH is low, below 7.35, and the bicarbonate is also low, that's a big hint. Acidosis can cause potassium to shift from inside the cells to outside.
Interesting.
It's all about balance, you see. Imagine the inside and the outside of your cells as needing to maintain a certain electrical charge. When there are too many hydrogen ions, which have a positive charge, floating around outside the cells, that's acidosis.
Right.
The body tries to fix this by moving some of those hydrogen ions into the cells.
Okay.
But to keep things balanced, potassium, which also has a positive charge, has to move out of the cells and into the bloodstream. That's how acidosis can lead to hyperkalemia.
So it's like a trait, one positive charge for another to keep things electrically neutral.
Exactly. It's like a seesaw. You need to keep both sides balanced.
Okay, that makes sense. So if we see acidosis, we should be thinking about conditions that cause this kind of potassium shift.
You got it.
What are some examples?
A classic example is diabetic ketoacidosis. In DKA, there's not enough insulin, so sugar can't get into the cells, and that leads to high blood sugar. At the same time, the body starts breaking down fat for energy, and that produces keto acids, which are acidic. So you end up with both high blood sugar and metabolic acidosis, and that drives potassium out of the cells and into the blood, causing hyperkalemia. Another example is renal tubular acidosis. This is a group of conditions where the kidneys can't regulate the body's acid-base balance properly, and that can also lead to acidosis and hyperkalemia.
So our first branching point is, do we have true hyperkalemia with acidosis? If yes, we're thinking about a shift of potassium out of the cells.
Right.
What if there's no acidosis? What if the pH is normal or even on the alkalotic side?
If the acid-base status is normal or alkalotic, then it's likely something else is going on.
Okay.
In these cases, we need to focus on the kidneys and how well they're getting rid of potassium. If the kidneys aren't doing their job, potassium builds up in the blood.
Got it. So the second decision point is acidosis, yes or no?
Yep.
If yes, think about those potassium shifts. If no, zero in on the kidneys. So how do we figure out what the kidneys are doing with the potassium?
This is where we get to a really crucial step, figuring out how much potassium the patient is peeing out, their urinary potassium excretion.
Okay.
This helps us tell the difference between two main types of hyperkalemia. Extrarenal hyperkalemia, where the problem isn't really with the kidneys themselves,
Okay.
and renal hyperkalemia, where the kidneys are the main culprit.
So how do we measure what's going on with potassium in the urine?
Well, there are a couple of important tools we can use. One is a spot urine potassium level, just a single urine sample.
Okay.
And the other is the ratio of potassium to creatinine in the urine. If the spot urine potassium is low, usually less than 20 milliequivalents per liter, or if the potassium to creatinine ratio is low, that tells us that the kidneys are trying hard to hold on to potassium.
Okay.
And if that's happening when the blood potassium is already high, it means that the extra potassium isn't coming from the kidneys not doing their job. Instead, it points to those extrarenal causes we talked about earlier, like potassium shifting out of the cells or the person eating too much potassium.
Okay, so low urine potassium means the kidneys are trying to conserve it.
Exactly.
And that suggests the problem lies somewhere else. What about the opposite situation? What if the urine potassium is high?
Well, if the urine potassium is high, typically more than 20 milliequivalents per liter, or if that potassium to creatinine ratio is high, then that tells a different story. It means that the kidneys are actually getting rid of potassium even though the level in the blood is already high. And this usually means that the kidneys either can't reabsorb potassium properly or they're not responding the way they should to aldosterone. Aldosterone is a hormone that helps control potassium levels by telling the kidneys to hang on to potassium.
Okay, so high urine potassium, even when the blood potassium is high, suggests a problem with the kidneys.
Yeah.
Specifically with how they're reabsorbing potassium or how they're responding to aldosterone. To get even more specific about what's going on in the kidneys, we have another tool we can use, the transdubular potassium gradient.
Oh yeah, the TTKG. That's a good one.
Yeah, the TTKG. Can you break that down for us? It sounds kind of complicated.
Sure. The TTKG is a number that gives us an idea of how concentrated the potassium is in the fluid at the very end of the tubules in the kidneys, where aldosterone does its thing. It's calculated using a formula. You take the urine potassium and divide it by the serum potassium. Then you take the urine osmolality, which basically measures how concentrated the urine is, and divide that by the serum osmolality.
Okay, I'm following so far. So that's the formula. But what do the different TTKG values actually tell us?
A high TTKG, like 7 or 8 or higher, means that there's a lot of potassium being excreted in that last part of the kidney tubules.
Right.
If someone has hyperkalemia and their TTKG is high, it could be a couple of things. It could mean the kidneys are working overtime to get rid of extra potassium because the person is eating a ton of it.
Right.
Or it could mean that potassium is temporarily shifting into the bloodstream, but the aldosterone system is still working fine. The main point is that the last part of the kidney tubules is doing its job of excreting potassium.
So a high TTKG, generally speaking, is a good sign. What about a low TTKG?
Well, a low TTKG, like less than 3, especially when someone has hyperkalemia, that's a red flag. It means the kidneys aren't responding the way they should to get rid of potassium.
Okay.
This could mean a couple of things. It could be hypoaldosteronism, meaning there's not enough aldosterone around to tell the kidneys to excrete potassium.
Wow.
Or it could be aldosterone resistance, meaning the kidneys aren't listening to aldosterone even though it's there. Conditions like type 4 renal tubular acidosis and primary adrenal insufficiency, those often have a low TTKG when there's hyperkalemia.
Okay, so that's our third decision point. Low urine potassium and low TTKG point towards the kidneys not excreting enough potassium.
Right.
High urine potassium and high TTKG mean the kidneys are trying to get rid of potassium, so we need to look at other causes, like intake or shifts. And I've heard that these urine studies and TTKG are showing up more and more on the MRCP lately. Is that true?
Oh yeah, absolutely. The people who write the MRCP exam are really keen on making sure doctors understand how to use these urine tests to figure out what's causing hyperkalemia.
So it's a good thing to know. So far, we've confirmed true hyperkalemia, checked the acid-base balance, and looked at how much potassium is being excreted in the urine. Now, we need to step back a bit and consider the bigger picture. What's going on with the patient's overall health? And super important, what medications are they taking?
Right, now it's time to put all the pieces of the puzzle together. We've got the lab results, and now we need to factor in the patient's medical history and their medications.
Because medications can often be the culprit when it comes to electrolyte problems, right?
Yeah.
What are some of the meds we should be thinking about, especially those that might affect the kidneys or that renin-angiotensin-aldosterone system, the RAAS?
Oh, there's a whole bunch of medications that can mess with potassium levels. Some of the most common ones are the RAAS inhibitors, like ACE inhibitors and ARBs. These drugs can interfere with how aldosterone is made or how well it works. And that can lead to the kidneys holding on to potassium. Then there are the potassium-sparing diuretics, like spironolactone and amiloride. These guys directly tell the kidneys to keep potassium instead of getting rid of it.
And sometimes other medications that you wouldn't necessarily think of can also contribute to hyperkalemia, right?
Absolutely. NSAIDs, beta blockers, heparin, even trimethoprim, they can all play a role.
Trimethoprim, really? That's interesting.
Yeah, trimethoprim can actually block a channel in the kidneys called ENANC, the epithelial sodium channel.
Okay.
And this is the same way that amiloride, a potassium-sparing diuretic, works. This effect of trimethoprim is especially strong in people who already have chronic kidney disease because their kidneys are already struggling to handle potassium.
Oh, that makes sense. So our next decision point is, does the patient have a history of taking any of these culprit medications?
Right.
If yes, it supports the idea that the kidneys aren't excreting enough potassium. If no, we need to consider other possibilities like high potassium intake or those shifts we discussed earlier.
Exactly. And while we're talking about medications and the kidneys, we should also think about checking hormone levels, specifically the hormones involved in that RAAS system, renin, angiotensin, and aldosterone.
When would you usually order those tests?
If we've done the initial workup and it looks like the kidneys are the problem, checking those hormone levels can help us pinpoint exactly what's going on.
Yeah.
For instance, if the aldosterone level is low and the potassium is high, it could mean the person has primary adrenal insufficiency, like Addison's disease or type 4 RTA.
Okay.
But if the renin is high and the aldosterone is low, that points towards hypoaldosteronism, which is pretty common in people with diabetes and chronic kidney disease.
So if the hormone levels are abnormal, it confirms that the kidneys aren't excreting enough potassium because of some kind of hormone problem.
Right.
What if the hormone levels are normal?
Well, if renin and aldosterone are normal, then it's less likely that a hormone issue is the main problem. That makes us go back to thinking about things outside the kidneys, like high potassium intake or shifts in potassium between the cells in the bloodstream.
Got it.
Oh, and here's a little board exam tip. Addison's disease, where both renin and aldosterone are low, that's something that pops up on the MRCP pretty often.
Good to know. We've already talked about how acidosis can cause potassium to shift out of cells. What are some other situations that can cause this kind of shift?
There are a few other things that can lead to potassium moving out of the cells and into the bloodstream.
Okay.
One is when there's not enough insulin, or the body isn't responding to insulin properly, like in DKA. If insulin can't do its job, sugar can't get into the cells, and potassium has trouble getting in too.
I see.
Another is when cells break down and release their contents. This can happen in rhabdomyolysis, which is when muscle tissue breaks down, or in tumor lysis syndrome, when tumor cells break down rapidly, or even just with really bad hemolysis. Beta blockers, especially the ones that block both beta 1 and beta 2 receptors, can also interfere with how potassium gets into cells. And even when the blood is too concentrated, meaning there's not enough water, that can pull water out of the cells, and potassium follows along.
Wow. So there are quite a few things that can trigger these shifts.
Yep.
Our last decision point then is there evidence that cells are breaking down or that there's an insulin problem? If yes, we're leaning towards a potassium shift.
Yeah.
If no, then the focus really needs to be on the kidneys and how well they're excreting potassium. Rhabdomyolysis is a big one to remember.
Oh yeah, rhabdomyolysis is a classic. You'll see it on the USMLE Step 2 and even on the neurology boards.
So by going through these steps one by one, we can really narrow down why the potassium is high. First, we confirm it's true hyperkalemia.
Right.
Then we look at the acid-base balance.
Yeah.
Then we check the urine to see what the kidneys are doing.
Yep.
And we look at the patient's medications, the medical history, hormone levels, and any signs that potassium might be shifting out of the cells.
Exactly.
Just building a case, to figure out what's going on. Now that we've explored the why behind hyperkalemia, let's dive into the how.
All right, let's do it.
How do we actually get that potassium level back to normal? And how do we do it safely?
When it comes to managing hyperkalemia, there's no one-size-fits-all approach.
Okay.
You really need to tailor the treatment to the individual patient.
Right.
Think about how high the potassium is, whether the EKG is showing any signs that the heart is being affected,
Right.
and any other medical problems the patient might have.
Okay, that makes sense. So let's start with the acute situations, those times when we need to act fast. What are the red flags that tell us we need to intervene right away?
We pull out all the stops when the potassium level is really high, usually 6.0 to 6.5 milliequivalents per liter or higher, or if we see changes on the EKG that tell us the heart is in trouble.
Got it. So in those situations, what's our top priority? What do we do first?
The absolute first thing is to stabilize the heart.
Okay.
When potassium is high, it can really mess with the heart's electrical system and cause dangerous arrhythmias.
Very.
To protect the heart, we give intravenous calcium,
Okay.
usually calcium gluconate, the 10% solution. We give it as an IV push, 10 to 30 milliliters over 5 to 10 minutes. You can also use calcium chloride, but it's stronger, and we usually only use it if the patient has a central line.
How quickly does the calcium work and how long does it last?
Calcium works almost instantly, thank goodness, and its effects on the heart usually last for about 30 to 60 minutes.
Okay.
It's super important to watch the patient's EKG the whole time you're giving calcium. And here's a big one to remember. It comes up all the time on cardiology and critical care board exams. You have to be really careful giving calcium to patients who have digitalis toxicity,
Right.
because it can cause something called stone heart, where the heart muscle basically gets stuck in a super strong contraction.
Oh, wow.
So calcium gluconate, that's your go-to first step for severe hyperkalemia, especially if you see EKG changes like peaked T waves or a widened QRS complex. Stabilize the heart, that's the immediate priority.
Protect the heart. Got it.
Ooh.
What comes next? We've stabilized the heart with calcium, but the potassium level is still high. What do we do to actually bring it down?
So once we've stabilized the heart, the next goal is to move potassium from the bloodstream back into the cells where it belongs.
Okay.
There are a few ways to do this. One of the most common and effective is giving insulin along with glucose.
Okay.
A typical dose is 10 units of regular insulin given intravenously, along with 25 to 50 grams of dextrose.
Okay.
We give the dextrose to prevent the blood sugar from dropping too low because insulin drives sugar into the cells. This combo usually starts working within 15 to 30 minutes, and the effect lasts for about 4 to 6 hours.
Okay.
It's really, really important to keep a close eye on the blood sugar. Check it every 30 to 60 minutes, at least at first. You don't want the patient to become hypoglycemic. This is something they really emphasize on critical care boards, and it's often missed on USMLE Step 2.
Got it. Insulin and glucose to shift potassium back into the cells. What are some other ways to do this?
We can also use beta-2 agonists like albuterol given through a nebulizer. The usual dose is 10 to 20 milligrams. It takes about 30 minutes to start working.
Okay.
But you have to be a bit careful with albuterol, especially in patients who have coronary artery disease or heart rhythm problems, because it can sometimes make those worse.
Right.
Another option is sodium bicarbonate given intravenously. We usually give 50 to 100 milliequivalents over 5 to 10 minutes.
Okay.
Bicarb is most helpful when the patient also has metabolic acidosis, a pH less than 7.2. If you use bicarb, you need to check the blood gases regularly to make sure you're not overdoing it and making the pH go too high.
So we've protected the heart and shifted potassium back into the cells. What's the last step in acute management? How do we actually remove excess potassium from the body?
All right, so the final piece of the puzzle in these acute situations is getting rid of that extra potassium for good.
Okay.
And we have a few tools for that. Loop diuretics, like furosemide, can help flush potassium out in the urine. We usually give it as an IV push, 20 to 40 milligrams. But for this to work, the kidneys have to be working well enough.
Makes sense.
You need to watch the urine output carefully and keep an eye on the other electrolytes too, especially in patients with chronic kidney disease or heart failure.
Okay.
Another option is using clarification exchange resins.
Okay.
You might remember sodium polystyrene sulfonate or kyaxylate.
Yeah.
You can give it by mouth or as an enema, 15 to 30 grams. The problem with kyaxylate is that it takes a while to work, several hours.
Yeah.
And there's a small risk of intestinal damage, especially in people who've recently had surgery or are really sick.
I feel like I haven't heard people talk about kyaxylate that much lately. Are there any newer options?
You're right, kyaxylate's not as popular as it used to be. We have some newer potassium binders now, like Pitiramer and sodium zirconium cyclosilicate, or SCC. Pitiramer usually starts at 8.4 grams a day, and you adjust the dose every week based on the potassium levels. The usual maintenance dose is somewhere between 8.4 and 25.2 grams per day. SCC is a little different. You start with 10 grams 3 times a day for up to 48 hours. Then you go down to a maintenance dose based on how well it's working, usually 5 to 10 grams once a day. These newer drugs are better for when the hyperkalemia isn't immediately life-threatening or for long-term management.
Okay.
Of course, you still have to monitor potassium levels and watch for side effects, especially GI problems. These new binders, they're becoming really important for the ABIM and cardiology boards, especially for managing heart failure patients who really need to stay on those RAS inhibitors.
That makes sense. So when do we need to consider dialysis?
Dialysis, specifically hemodialysis, that's our last resort for hyperkalemia. We use it when nothing else is working, what we call refractory hyperkalemia, or when the patient has really bad kidney problems, like end-stage renal disease. Hemodialysis is the fastest way to get potassium out of the body. You need to watch the EKG closely during dialysis and check the labs afterwards to see how things are looking.
So for acute hyperkalemia, the kind that needs urgent attention, especially if the EKG is abnormal.
Right.
It's a 3-step process.
Yep.
Stabilize the heart with calcium, shift potassium back into the cells using insulin and glucose, and maybe albuterol or bicarb, and then get rid of that extra potassium for good using diuretics, binders, or dialysis.
Exactly.
Now, what about patients who aren't in immediate danger, but they have chronic conditions that make them prone to hyperkalemia? How do we manage those folks long term?
Good question. For patients with chronic conditions who are always at risk for hyperkalemia, even if their potassium isn't critically high right now, the goal is to prevent it from happening in the first place and to manage it carefully if it does. So the first thing is to look at their medications. If they're on any drugs that can cause hyperkalemia, see if we can adjust the dose or maybe switch to something else.
Right.
We might think about lowering the dose or even temporarily stopping RAAS inhibitors or potassium-sparing diuretics.
Okay.
But we have to be careful, especially in patients with heart failure or chronic kidney disease, because those RAS inhibitors are really important for protecting the heart and kidneys.
Yeah.
So sometimes it's better to add a potassium binder than to stop those drugs. If they're on NSAIDs or beta blockers, we might need to adjust those or find substitutes if they're contributing to the problem.
And lifestyle factors are important for long-term management too, right? Like diet.
Oh, absolutely.
Yeah.
It's crucial to talk to patients about their diet, make sure they understand which foods are high in potassium and how to limit those.
Right.
For people with chronic kidney disease, it's a really good idea to have them meet with a dietitian who specializes in renal diets.
Makes sense.
For long-term management, we also often use potassium binders. We start with low doses of Patamer, usually 8.4 grams a day, or SEC maybe 5 grams once a day, and then we go up slowly based on their potassium levels, checking those every 1 to 2 weeks at first, and then monthly once things are stable. We also have to keep an eye on their magnesium, sometimes their calcium, and make sure there aren't any drug interactions because binders can affect how other oral medications are absorbed, so we might need to have them take their meds at different times.
Okay.
And one more thing, you got to be careful using these binders in people who have problems with their bowels not moving things along properly.
Good point. Are there any special things to keep in mind for certain groups of patients when we're managing hyperkalemia long-term?
Definitely. People with chronic kidney disease, they need really close monitoring of their potassium levels for obvious reasons.
Yeah.
For folks with diabetes, we have to be super careful with insulin dosing because insulin can both help control blood sugar and move potassium into cells.
Right.
And in DKA, fixing the acidosis is really important. Not just for the potassium, but for the overall metabolic picture. For patients with adrenal insufficiency or hypoaldosteronism, like type 4 RTA, we might consider giving them a low dose of fludrocortisone if there's nothing preventing us from doing so. Fludrocortisone is a drug that acts like aldosterone.
Okay.
We usually start around 0.1 milligrams per day and then adjust the dose based on their blood pressure and potassium levels. We have to watch their blood pressure and fluid status like a hawk because they tend to have a low TTKG.
So in summary, managing hyperkalemia long-term is all about being proactive, right?
Exactly.
Reviewing medications, adjusting the diet, considering those potassium binders, and keeping a really close eye on things, especially in people with chronic kidney disease, diabetes, or adrenal problems.
You got it.
This has been such a thorough rundown of both acute and chronic hyperkalemia management.
Yeah.
Super helpful and packed with things that are going to show up on those board exams. Now, let's get specific about those exams. We all know hyperkalemia is a favorite topic for the test writers.
Oh, yeah.
What are some key takeaways, those pearls and pitfalls, that our listeners should really burn into their brains for the USMLE, ABIM, and MRCP?
Hyperkalemia is like a greatest hits album for board exams, especially when they're throwing questions about kidney disease, medications, and critical care at you. Lately, the exams have been focusing more on the new treatments for hyperkalemia, like those potassium binders, and also on the common mistakes people make when diagnosing and treating it.
Okay, let's start with those high-yield pearls for diagnosing hyperkalemia. What are the absolute must-knows for exam day?
Okay, here are a few things to remember. First up, let's talk about a classic red herring, pseudo-hyperkalemia. This one is super common and super misleading. If your patient's clinical picture doesn't quite match that elevated potassium level, hit the brakes, especially if there's no chronic kidney disease or no classic symptoms. Always, always repeat that potassium. A hemolyzed sample, tight tourniquet, or rough venipuncture can easily skew results.
And here's the trap. Even in true hyperkalemia, the ECG can look completely normal. I'll say that again, completely normal. Don't get too comfy just because the monitor is quiet. A normal ECG doesn't rule out danger.
Let's shift gears to the transtubular potassium gradient, or TTKG. It's a helpful tool in figuring out where the potassium problem is coming from. If the TTKG is less than 3, think aldosterone issues. Type 4 renal tubular acidosis or Addison's disease are common culprits, but if it's over 7, that usually points to renal potassium loss, so check diuretics, vomiting, or other causes of high output states.
Next, let's spotlight diabetic ketoacidosis, or DKA. This one's sneaky. You might see a high or normal potassium level on labs, but don't be fooled. These patients are actually potassium depleted at the cellular level. Insulin drives potassium back into cells, so when you start insulin therapy, potassium levels can plummet. Start insulin, but go slow and monitor electrolytes closely.
Now onto a big one in chronic care: ACE inhibitors and ARBs. These meds are fantastic for renal protection, especially in CKD and heart failure, but they can also cause chronic hyperkalemia. Knowing when to hold or adjust these medications is crucial. Monitor potassium trends and renal function regularly. And finally, a board favorite and a critical clinical pearl: digoxin toxicity. If your patient is on digoxin and hyperkalemic, never give IV calcium. It might seem counterintuitive, but it can cause stone heart, a rigid, non-contractile myocardium. That's a one-way ticket to cardiac arrest. It's an instant fail on the boards and a fatal error in real life.
All right, let's bring it all home with a bonus case. We've got a 68-year-old man with CKD stage 4 diabetes and hypertension. His potassium is 6.7, creatinine 3.2, ECG shows normal sinus rhythm. He's on lisinopril, spironolactone, and metformin, but no symptoms. So, what's the next best step? A. Stop ACI and spironolactone. B. IV calcium and insulin. C. Start pataromer and recheck K+ in 48 hours. D. Start hemodialysis.
And the correct answer is C. He's stable, ECG is normal, and he's asymptomatic. So no need to panic. Treat with pataromer and recheck in 48 hours. No need to pull all his meds or rush into dialysis. Be calm, be clinical.
Let's wrap up. Hyperkalemia is a minefield of misleading signs. Always correlate clinically, confirm suspicious labs, and think physiologically. From pseudo-hyperkalemia to TTKG and medication effects, being systematic can save lives.
Thanks for tuning in to Modern Medics. If you found today's episode helpful, share it with a colleague or drop us a review. Until next time, stay curious and stay clinical.